Good evening to everyone and welcome to today's session. So today's exam has got a mix of questions from the COMEDK, some from the JK entrance and few more original questions. I hope you liked it. So let us make the start of the discussion. The sacral tuberous ligament is the degenerated tendon of which important muscle fundamentally? The sacral tuberous ligament, it is situated in the lower and the back part of the pelvis, and it runs from the sacrum to the tuberosity of the ischium, and it is a long head of the biceps femoris, which is considered to be the extension of the sacral tuberous ligament, is what you need to fundamentally appreciate. Urogenital diaphragm, what does it basically consist of? Fundamentally, in the, you know that there is a superficial and a deep perineal pouch, and the separating part is the urogenital diaphragm, and it is the deep transverse perineum and the sphincter urethrae which constitute the components of the urogenital diaphragm, is what you need to remember, doctor. One question in the tomorrow's exam invariably is going to be in the state entrance. The superficial deep perineal pouch, what are their boundaries, constituents? 200% you should be sure, because this is one topic constantly asked in the entrance exam out of the 5 anatomy questions which are going to come. Now, what are the boundaries of the epiploic foramen? Typically, in front there is the free border of the lesser omentum with the common bile duct, hepatic artery and the portal vein, and behind there is a peritoneum which is overlaying the inferior vena cava, and above is the peritoneum of the caudate process of the liver, and below is the peritoneum which is covering the first part of the duodenum and the hepatic artery. So that is how the epiploic foramen is being bounded on the roof, the floor, the front and the back, is what you should be very sure. Cecum, what are the posterior relationships of the cecum? This one illustration will be eye opener, doctor, to explain everything. You can see here, this is the cecum. The iliolumbar artery, are you able to appreciate it here, doctor? Is the posterior relationship of the cecum. Similarly, here you are having the iliacus muscle, the psoas muscle, and the lateral cutaneous nerve of the thigh also is typically located. But where is the testicular artery? Typically, this is the testicular artery. Testicular artery does not go as a posterior relationship to the cecum all the way. It is a little more medial. So it is not the testicular artery is not the part of the posterior relationship. All the remaining 3 is what we have to fundamentally appreciate. Now you have a sarcoplasmic reticulum. You are having the T-tubular system. So T-tubules basically pass between the myofibrils. Sarcoplasmic reticulum provides energy, and along with the T-tubules, the sarcoplasmic reticulum, in the case of the skeletal muscle, will form a triad. In the case of the smooth muscle, it will form a dyad. You know very well, you need to basically review that little literature which I have supplemented to you. Saltatory conduction means the electrical impulse will be jumping from one node to the other node. Why it cannot come back? Because when it jumps from this node to the next node, the previous node will be in a refractory state. So it cannot become once more depolarized. So that is the reason there can be only one-way conduction of the nerve impulse, but not a reverse two-way. It cannot be there, because the previous node of Ranvier, from where it has jumped, will be in a state of refractoriness for the further depolarization, is what you have to fundamentally appreciate. What is the reason for our pleasure? Dopamine. For our depression, dopamine. For our psychosis, dopamine. So we are all dopamine dependent human beings. where our happiness is a state of mind of availability of the dopamine, is what you have to be very sure. In the carotid pulse, how much minimum systolic BP is required? Actually, one key that was given in the Comet K was option A, 40, but I will give you another very good literature reference for this. Typically, pedal pulse, if you want to feel, 90 millimeters mercury of systolic pressure should be there. No pedal pulse but radial pulse, systolic BP should be at least 80. No radial pulse but femoral pulse, then systolic BP should be 70. And if the patient has no femoral pulse, and if you want to find carotid pulse, at least 60 millimeters of mercury of the systolic BP need to be present, is what you have to be very sure. Dopamine, one of the mechanisms is basically by decreasing the sodium potassium ATPase activity is the secondary messenger system and mechanisms of action of various hormones and neurotransmitters is one of the favorite topic for the examiner. Sodium ion is typically least in the case of the gastric juice. After the carotenes get absorbed in small intestine, they become converted into vitamin A. Lipoprotein X is the one which is associated with cholestatic jaundice. And what is the main mechanism of pathogenesis? I left in the literature for you to review how does it lead to the development of cholestasis. What is meant by hydrogenation of oils? Typically it leads to the formation of the trans fatty acids which are more dangerous in vanaspati, dalda, etc. They are all basically the trans fatty acids after hydrogenation which are more vulnerable to lead to the free radical generation, is what you have to understand. If you look at the amino acids, whenever the amino acids undergo oxidation, where do they undergo? Typically in peroxisomes. You have a L amino acid oxidase. It typically uses flavin mononucleotide as the important acceptor of the hydrogen ions, is what you have to appreciate. And in some people, L amino acid oxidase deficiency in the peroxisome can lead to the development of hyperaminoacidemia, and encephalopathy can be the presenting feature. Cysteine, methionine, cysteine, I think very easy question. They are all basically sulfur containing amino acids. What is the difference between MHC1, MHC class 2 is another very frequently asked question. So MHC class 1 is typically found on every nucleated cell of the in the body. Since RBC has no nucleus, there is no MHC. Class 1 is typically understood. And what is the way by which MHC1 function? Major histocompatibility complex class 1. Typically it is also called endogenous or cytosolic pathway, where it will be presenting the foreign proteins, become immunogenic and presentable to the immune cells for further phagocytosis, which is the underlying mechanism. Theory of contagion, who enunciated it? It is basically the Girolamo Fracastoro. I think Vesalius was in the key which was originally given, but it was Girolamo Fracastoro is the one who said that infections are transmitted by disease seeds which are carried by the wind. 1546 means not very far. 450 years back, people were all thinking like fools that it is the seeds of wind, witchcraft, etc. Imagine another 200 years later, maybe the knowledge will be totally different, and if at all human race exists. Now the phosphatase test is typically used to know the efficacy of the pasteurization of the milk, all of you know very well. Endotoxins, exotoxins, what are the differences is one of the very common table in the microbiology, Ananthanara, and as you open it will be visible for you. First chapter of bacteria, endotoxins, exotoxins, gram negative, gram positive, classification, everything. So doctor, there is no enzymatic activity for endotoxin, unlike an exotoxin which often has got an enzymatic activity. So that table somehow you have to fix it up into the brain and go to the exam hall. Hepatitis B envelope antigen, not core antigen, is a marker of active infection. Histoplasma is an invasive fungal infection, not a superficial fungal like dermatophyte. It is not like dermatophyte is what you have to understand. Now what are the various drugs that lead to diabetes insipidus and Sa Adh? Very standard question. So this had been a very common question since times immemorial. Causes of Sa Adh: barbiturates, vincristine-like drugs, vinca alkaloids, carbamazepine, haloperidol, opiates, nitrous oxide. Lot of drugs have been implicated in the causation of Sa Adh. One monoclonal antibody against you like adalimumab etc. will definitely be asked. That is our deal, is it not? We had been saying it since a very long time. One question compulsory will be on one monoclonal antibody. So adalimumab, certolizumab, etanercept, infliximab and golimumab, all Afghanistan names, they are all fundamentally monoclonal antibodies against TNF. But what is apiximab? Apiximab is a platelet aggregation inhibitor which is typically used in those who are having a coronary artery procedure like angioplasty. It is a glycoprotein 2B3A on the platelets. It is the inhibitor against it. Even for that we are ready when we had gone to exam. Because one question on antiplatelets and heparin and thrombolytics, streptokinase, urokinase, TPA, advantages which is thrombus specific, which is not, how the life is unfortunately too predictable. A life too predictable is also very boring. Be very sure doctor, entrance is like that. Anthracycline's cardiotoxicity is prevented basically by dexaroxazone. And what is the mechanism? Dexaroxazone is a congener to EDTA, and it will be basically chelating the iron and reducing the metal ions complexing with anthracycline and decrease the superoxide radical formation, which is mainly responsible for the anthracycline induced cardiotoxicity, is what you have to basically remember. Lithium side effects, digoxin side effects. Invariably one question will be there on the adverse effects, therapeutic concentration, mechanism of action, everything about these two drugs doctor, lithium and digoxin, you have to be sure. So there can be weight gain, not diabetes mellitus, nephrogenic diabetes insipidus, and there can be downbeat nystagmus and cerebellar dysfunction and renal dysfunction. All these are possible side effects of the lithium. Atracurium is the best drug not metabolized by kidney, hence the best drug that you can give for a renal failure patient is what need to be remembered. One mechanism of the antibiotics, which are protein inhibitors, 50 years, 30 years, 70 years, 80 years, cell wall synthesis inhibitors, gyrase inhibitors, everything you have to be sure doctor. So vancomycin is not clindamycin. Clindamycin, erythromycin, all these are protein synthesis inhibitors. Vancomycin basically is an inhibitor of the cell wall in the gram-positive organisms is what you have to fundamentally remember. Nodular bronchiectasis, classically where do you find? It is also called Lady Windermere syndrome. Typically, when Mycobacterium avium intracellular infection occur, then it leads to development of a nodular bronchiectasis. In the Oscar Wilde's play, Lady Windermere character, similar symptoms will appear, hence called Lady Windermere's disease. Mycobacterium avium intracellular, MAC lung disease, otherwise is basically nodular bronchiectasis. Dystrophin is the largest gene expressed in the cardiac and smooth muscle, but it does not lead to the formation of the largest protein produced in the body. What is the largest protein in the body produced? Titin. Longest protein, titin. But titin is not produced by the dystrophin, but dystrophin is the longest gene known to be present, and it is present on X chromosome, is what you have to basically appreciate. Meniere's is that hyperplastic gastropathy where the protein loss, parietal cell atrophy, etc. will occur, and it is pre-malignant condition and can lead to the development of stomach cancer, gastric cancer at a later point of time. So these are those hypertrophied folds inside the stomach in this typical section of the stomach on CT in case of the Meniere's. What's the most common site of extranodal lymphoma? So I got one key as skin, original key, but it is the stomach, gastrointestinal most common. In that stomach is the most common extranodal site for the development of the lymphoma, is what you have to basically appreciate. Atypical hyperplasia has got a very high tendency to lead to the development of malignancy. Actually, original Comet KMA option B was albumin, but albumin is also part of the Child-Pugh classification. So we altered it, so transaminases are not a part, but otherwise banana, B for bilirubin, A for albumin, N for neurological status, that is encephalopathy, and one more A is for ascites and prothrombin time. These are all the components of the Child-Pugh classification. Indian Evidence Act had been enacted since 1872. Then arsenic is detected by the Marsh test, is a very common Marsh. Rinska? Both A and B. Oh, I only focused on Marsh. I think original Comet K also they have given both. Famous mistakes in famous exams can be there. So we will alter that. Now with regard to the evidences, the medical legal report, accepting that all the remaining, the dying declaration, chemical examiner report, reporter of the master of mint, and a fact written in the entrance coaching book, they all don't need oral evidence. You need not pull the author. Of course, in a live classroom you can always protest. Now with regard to the medical witness, a doctor, what is your role in the court of law? In helping the court, not in misleading the court. In basically finalizing what went wrong by using your expert medical knowledge. All of them are in fact useful for establishing identity, fingerprinting, etc., etc. In wheat it is the lysine which is the limiting amino acid. Cohort is an example of an analytical study. 0.5 to 3 microns is where you call it as pneumoconiosis. Now comes the question on vase. The other day what is our deal? Green bag, yellow bag, category 1, category 2. one question will definitely be there on waste disposal. Got it, doctor? So any waste which need to be incinerated should not have a moisture content above 30%. Only when the moisture content is less than 30% you can burn it. Common sense na? Agar ज़्यादा water रहे तो if you burn it won't burn. No big deal. I mean what you need is to carry your brain to exam hall. So I mean to carry your common sense to the exam hall, doctor, let me tell you. It will help a good number of times. Don't worry about number of facts that you have amassed. It doesn't matter. In the middle of the battlefield, no warrior can really use his senses. I mean, no warrior really uses his talent. He needs to survive the moment, use his common sense, and give the best guess that he can. And the best guesser is called as the one who kissed the the top rank. So that's the only thing. Thermoactinomyces sakari is typically found in the case of the Begasthosis. Anybody answered Bicinosis? If you got that slightest doubt, Begasthosis, Bicinosis still even now, then you are basically suffering Braxton Hicks in a moment where you are expected to have labor pains. So be very sure that you should be able to vomit out the answer without any retching or malarious efforts. You must be sure, doctor. What is DOTS? S is basically for the short course. Now what is the first step in planning the cycle of health? Anybody answered it as fixing priorities? No. Huh? Or anything other than option C? Any? Yeah, I know. So the first step is analysis of health situation. First you should analysis. There are multiple steps given in the last pages of the park. What are sampling, non-sampling errors? So basically one sample differed to some extent from the results of another sample. This kind of a variation is called sampling error. And why does it occur? Because the data is gathered from a sample instead of the entire population which need to be evaluated. Whereas non-sampling errors, why do they basically occur? Instruments used are different, observer variation, incomplete coverage, etc., etc. They are all the reasons. 1995 we have launched under WHO initiative the pulse polio immunization program. It is the 4 to 5 milligrams is what we give the folic acid. Now comes the cow's milk and human milk. Without that you will have definitely one glass of milk in the exam hall. Without a question on milk, it is out of question. Typical examiner's suckling tendency. So they won't leave a paper without that satiety doesn't come without giving a question on milk. Be very sure, doctor, if you don't remember this table of the park, cut it, carry it and copy it in the exam hall, whatever you do. So 33 grams per liter is cow's milk, breast milk is only 11 grams per liter is what you have to basically remember. Divided by 10 will be per 100 ml, at least that you should be sure. Now comes what quantity of water is needed in urban areas. If you could not answer milk question, you have still water question available in the entrance exam. So 160 to 200 liters per person per day. Isliye that's what I am saying to you, doctor. If you could not get a seat in MD entrance, take another 3 months of time and take the civil services prelims. You are using all the brain is all destroyed by too many 19 subjects. वहाँ तो 4-5 subjects, अकबर कब बनाया, रेड फोर्ट कब बनाया, फ्लैग होइस्टिंग कौन किया, कितने कलर्स है फ्लैग में, If you know few things, finish. After that you can become IAS, you can do few scams, you can go to jail. All this will be there in the history. Finally you can write my experiments with scams. One beautiful book. And you are a very powerful man. Who will care, doctor? MBBS doctor means a IAS officer, if he says stand, you need to stand, sit, you need to sit. But he will be thinking, array, he did only BA, I did MBBS, but still I need to stand or sit like a robot if the collector saab bole to. So that's the reason, don't worry, lot of entrances are there, even if you lose the seat in MD, but still you should get in MD. Now 55-year-old crushing chest pain. What is very indicative of myocardial infarction, acute coronary syndrome? It is ST segment elevation or depression, because Q waves will take time. There may not be Q waves like a non-Q wave MI. Troponin also will take time. So that is the reason ST changes are important. Troponin will take about 12 hours. Chest pain radiating straight to the back between the shoulder blades, classical of the aortic aneurysmal rupture. 44-year-old with headaches, with anxiety, sweating and a slow pulse rate, BP 150 by 95. And what is the most and best diagnostic investigation? Undoubtedly it is a urinary metanephrine, so a 24 hours period is considered to be highly sensitive and specific. Whereas random plasma catecholamines are not good because they can be normal between one flushing headache episode and the other headache episode. MRI is typically indicated only once the diagnosis is definite or highly probable. Then only MRI is indicated in a patient presenting with hypertension where you are suspecting FEO. A 25-year-old with mitral valve prolapse with low-grade fever with vasculitic lesions on the finger pulse. What are we thinking about? Infective endocarditis, typically diagnosed by the blood culture, which will be positive. A 58-year-old who is having COPD is having a very low FEV1, and what is the best drug that you want to fundamentally start for him? And he is already on salbutamol. Salbutamol comes under which group, doctor? Short-acting beta-2 agonist, SABA. So if the SABA, if he is not responding, you need to give him a LABA, which is a long-acting beta-2 agonist, like a salmeterol is the one which need to be basically introduced. Or you can also give him a LAMA, not left agonist medical advice, that is long-acting muscarinic antagonist, which would be ipratropium bromide is the one which need to be fundamentally administered. So I leave to you all the recommendations of management of the COPD and his bronchoconstriction in the literature given to you. You need to review it, doctor. Now a 45-year-old who is basically diabetic, after taking TB drugs has developed that peripheral neuropathy, which is a common side effect of INH, is what need to be remembered. Now a 47-year-old is having dysphagia and symptoms when swallowing the solids but not liquids. So that is more likely to be a neuromuscular dysphagia, which can be explained by achalasia. All the other are obstructive causes. Now a 47-year-old with 3-month history of epigastric dull abdominal pain. Abdomen is soft and he states that the pain is worse in the morning and relieved by taking food. Is very classical of, you all know, duodenal ulcer. Whereas gastric ulcer, he is afraid to eat food. So loss of weight is a feature of gastric ulcer. Gaining of the weight is a feature of duodenal ulcer, because food basically relieves the pain in case of duodenal ulcer. Emphysema, jaundice, ascites, you are thinking of alpha-1 antitrypsin deficiency. What is the mechanism of transmission? It is basically chromosome number 14, autosomal recessive disorder is the type of the inheritance. 56-year-old with a history of the jaundice with polyarthralgia, and there are several spider nevi on the front and back of the trunk, and anti-soluble liver antigen is detected. Too much of facts. So it is clearly a case of a autoimmune hepatitis, which need to be basically treated, especially whenever a patient is having a liver dysfunction on a lefty with all the viral serology. Whenever liver transaminases, everything elevated, first thing we think of viral cause. So all viral serology being negative and soluble liver antigen SLA positive is in favor of an autoimmune hepatitis, which can be treated by giving prednisolone, is what need to be remembered. But what is the challenge of prednisolone, doctor? Always remember in clinical practice, whenever you give corticosteroids, they themselves can lead to a rise of the liver function tests. So sometimes it becomes challenging to monitor the LFT in a patient receiving already steroids. So my 28-year-old has undergone sigmoidoscopy, rectal biopsy showing a crypt abscess, goblet cell depletion and mucosal ulcers with inflammatory infiltrate. So all these things are highly suggestive of ulcerative colitis, which starts at the rectum, spreads proximally in a continuous fashion, and it tends to not spread beyond the ileocecal valve, but can lead to a condition called backwash ileitis, which can very much be seen. Now non-caseating granuloma with a transmural inflammation is what you see in the case of the Crohn's. Then what is very characteristic of pseudomembranous colitis, doctor? You have this kind of an appearance. Colonic crypts with accumulation of neutrophils with necrotic epithelial cells is called as a summit lesion. It is called as a typical summit lesion is a feature in case of the pseudomembranous colitis. Pitting edema of the ankles, there is hypertension, low albumin, urine test showing positivity for the proteinuria. So what is the most important test that you want to fundamentally do, or intervention you want to do? All these are the classical features of nephrotic syndrome. So you need to start him on diuretics and restrict the sodium intake is the first step you want to basically do in case of nephrotic syndrome. And you should discourage the bed rest, because already the nephrotic syndrome is a procoagulant condition. So if you ask him to bed rest without anticoagulation, he may end up in a very good, beautiful DVT. Now a 65-year-old with hematuria with a BP of 128/83, and he had been a smoker since the age of 16, and he received herbal remedies and lost the weight, and he's noticed that there is a weight loss in the last 1 week in spite of stopping the remedies. What is the most likely cause? Those who smoke for a long period of time, which malignancy is very common, doctor? Bladder carcinoma is very common. But why not Chinese herb nephropathy? But Chinese herb nephropathy presents like an end stage renal failure with hypertension, proteinuria, hematuria, and in a very aggressive clinical course, which is not so in this given case. Now a HIV patient suffers from a ruptured aortic aneurysm and rushed to the theatre, and he is recovering and in a very stable state, and one day after the operation he becomes oliguric, polyuric with GFR of 30. What is the likely cause? Whenever anybody loses a lot of blood and suffers significant hypotension for a long period of time, they suffer from acute tubular necrosis, which can be one of the important complications which can occur, which presents in the form of salt losing state with hyponatremia, is what you have to fundamentally appreciate. 19-year-old type 1 diabetic individual had been treated with, is worried about diabetic nephropathy. What is the best way that you can monitor for a possible development of diabetic nephropathy? Is the microalbuminuria, That's the reason the urinary protein creatinine ratio is a gold standard for early diagnosis of the microalbuminuria. Tomorrow as physicians, day in and day out in the OPD, you will be prescribing urine examination religiously in your patient who had been treated for the diabetes. You are not only treating the diabetes but also his kidney, his eyes, his nerves and all the end organ complications of the diabetes. You must be closely monitoring like a cricket umpire without letting a catch out. Now a 21-year-old had mild eczema. Light microscopy, renal biopsy is normal. Electron microscopy, diffuse effacement. What is your diagnosis? Nephrotic syndrome. Most of the times the minimal change disease is responsible, which responds excellently to the prednisolone is what need to be remembered. 28-year-old typically presents with the blood pressure which is increased with the bruises on the arm and the face which is flushed and more rounded with Cushingoid appearance. So how do you want to basically prove the diagnosis first of all? So mainly you need to show that it is a state of hypercortisolism. So the first investigation to be done would be a 24-hour urinary free cortisol level. And then you will be doing a low dose dexamethasone test. If it were to be due to Cushing's disease or the Cushing's syndrome but not adrenal cause of hypercortisolism, then there is no suppression of the ACTH with a low dose dexamethasone. So mainly low dose dexamethasone, what will it do? It will differentiate adrenocortical causes of the hypercortisolism from the non-adrenocortical causes, because non-adrenocortical causes due to high ACTH levels, their low dose dexamethasone if you give, it won't suppress. There is adrenal causes, it will, the differentiator. Then you want to differentiate whether it is due to Cushing's disease or Cushing's syndrome. Disease का मतलब क्या है? If at all it is due to a pituitary adenoma which is producing excessive ACTH, you call it as Cushing's disease. Whereas any other cause like ectopic ACTH production, etc., any other cause of high ACTH is called Cushing's syndrome. And you want to differentiate between the two, then you can use the high dose dexamethasone suppression test fundamentally, because only in the case of the pituitary adenoma associated Cushing's disease, high dose dexamethasone will lead to suppression, whereas ectopic ACTH, if it is due to, then there will be no suppression, which is the primary differentiator between the two. Now a 47-year-old with 2 months history of tiredness, despite wearing several items of clothes, he is intolerant to the room temperature. There is an increase in the weight, particularly around the waist. Then what is your likely diagnosis, doctor? Hypothyroidism. And the best way to investigate it is TSH. And you don't expect T3, T4 to fall down. They may be within the lower limit or within the normal range of the normal range, whereas TSH become elevated typically. Now a 41-year-old type 2 diabetic individual and the BMI is 23 and fasting plasma glucose is 164, HbA1c is 7.1. BMI 23 means a thin fellow or a very fat fellow? Thin fellow. Always for thin fellows you can give sulfonylureas, fat fellows you can give metformin. That's a simple rule. So that is the reason you need to fundamentally treat him by giving the sulfonylurea, which become the first line of the treatment, is what you have to fundamentally appreciate. Now a 60-year-old receiving 0.9% saline for 2 days for hypotension now develops acidosis with chloride of 119, sodium potassium 147, 3.5. Then what are the most likely diagnosis in his given case? You all know very well, anybody who had been treated with normal saline pushing a lot of chloride will develop a normal anion gap metabolic acidosis. What is the other name given for it? Hyperchloremic metabolic acidosis, which can very much occur. So what is the anion gap in his case? Sodium plus potassium minus chloride plus bicarbonate. So 147 plus 3.5 is how much? 150 minus 119 plus 19 कितना हो गया? 138. 150 minus 138 is around 12. 8 to 12 is around normal value, normal anion gap. So normal anion gap metabolic acidosis, which is called hyperchloremic metabolic acidosis, can occur in any person in whom you are dumping saline, which is carrying the chloride ions, is what you have to fundamentally appreciate.